Hello and welcome to Chapter 23, Behavioral and Psychiatric Emergencies and Suicide. So we are going to look at behavioral and psychiatric emergencies and care for those behavior and psychiatric emergencies. So patients can present with unexpected or dangerous behavior. It can be result from stress, physical trauma, illness, drug or alcohol abuse, psychiatric conditions, anything like that. So then let's talk about what is a behavioral emergency. So behavior is a manner in which a person acts or performs, and a behavioral emergency is a behavior within a given situation that's unacceptable or intolerable to the patient, family, or community. So behavioral patients may appear confused and have altered mental status. Psychiatric conditions include anxiety or panic disorder, depression, bipolar disorder, or schizophrenia. So physical causes of altered mental status. So we've got medical and traumatic conditions that can alter a patient's behavior, such as low blood sugar, lack of oxygen, stroke or inadequate blood to the brain, head trauma, mind-altering substances, and environmental temperature extremes. So situational stress reactions. So there's normal reactions to stressful situations that produce emotions. Okay, so fear, grief, anger, those are all normal emotions to a stressful situation. Caring for these patients with those situational stress reactions, we don't want to rush them. We want to tell them that we're here to help them. Remain calm. Keep your emotions under control as well. Listen to the patient. Be honest and stay alert for any kind of changes in behavior. So acute psychosis, this involves a severe break in the patient's ability to process information and interact with their environments. Often associated with a cognitive disorder such as schizophrenia. Symptoms include hallucinations, delusions, catatonia, which is like they just kind of shock type deal. They just kind of stare off into space. They're catatonic. They don't do anything. Thought disorder, where their thoughts are all kind of a jumbled mess. And we want to ensure safety of the patient and us as well. So, assessment and care for behavioral and psychiatric emergencies. There's a range of presentations that can occur with these patients. They can be withdrawn and not communicating. They can be talkative and agitated. They may be bizarre or have a threatening behavior. They wish to harm themselves or others. So some key techniques: identify yourself and your role, speak clearly and slowly, and make eye contact. These patients, I tell them all the time, if, I'm not a cop, I don't care what you did, all I want to know is to make sure that you're okay. So that puts a lot of trust in me, or in that relationship. So, I just want to make sure that they're okay, that, I don't need to do anything for them, or if I can help them, I will help them. So listen to your patient. Remember, we should be doing about 80% of the listening and 20% of the talking. Especially with these patients, they need to talk. So even if there's a silence, most people don't like silence, so they're going to talk. Okay? Don't be judgmental. Use positive body language. Don't put your hands on your hips. Don't cross your arms. Don't give a look of disdain or anything like that. Try and control your facial expressions as well. Don't roll your eyes or anything like that. And acknowledge your patient's feelings. Do not enter the patient's personal space. We want to stay at least 3 feet away from that patient, because because if we get closer, we're opening ourselves up to being grabbed or being hit or anything like that. And be alert for any kind of changes in the emotional status. Use restraint to prevent harm if necessary. Okay, so plan your approach in advance and remain outside of the range of the patient's arms and legs until you're ready to act. If you have enough people, somebody can take care of the head and make sure that you're not bitten. I don't know that this is a good way unless they're like getting ready to take this patient down to the ground. Verbal de-escalation goes a long way. I would suggest reading the book Verbal Judo. It kind of goes along the lines of getting your patient to do what you want them to do, thinking that it was their idea. So Verbal Judo is a good book to read, especially with verbal de-escalation. But yeah, I mean, you want to make sure that you, unless they're getting ready to attack this patient, take them down to the ground, then it's probably not a good idea to have this kind of stance with that patient. So in our patient assessment, we're going to do a careful scene size up, making sure that we've got scene safety as much as possible. If they're agitated before we get on scene and dispatch knows that, then they're going to call for PD and we're going to stage. Identify yourself and your role, complete the primary assessment, perform as much of the detailed exam as possible, and gather a thorough history. So common signs and symptoms include panic and anxiety, unusual appearance, disordered clothing or poor hygiene, agitated or unusual activity, unusual speech patterns, bizarre behavior, thought patterns, suicidal or self-destructive behavior, violence or aggressive behavior. So we want to be alert for personal or scene safety problems. Make sure that you have a way out, that you know the exits, and that you have something ideally in between you and the patient. Treat any life-threatening problems if you can. Consider medical or traumatic cases. So consider that this patient may be a diabetic and their sugar is low and they're not happy. Okay, or consider that they may have just had a seizure and they're confused. They start coming up swinging and various things like that. Spend time talking to the patient. I say talking with the patient, listening to the patient. Encourage patient to discuss feelings, never play along with hallucinations, and consider involving family or friends. So suicide, it's the 8th leading cause of death. It's the 3rd leading cause of death in the age group ranging from that 15 to 24 years old. Rising numbers in the older adult population. Potential or attempted suicide, they explore the following possibilities: depression, high stress levels, current or recent emotional trauma, drug and alcohol abuse, and again that age range of 15 to 25 and 40 plus that are at that higher risk. Threats of suicide plan, previous attempts or threats, and a sudden improvement from depression. One thing that you always hear when people talk about somebody who's committed suicide is the fact that they were so happy, they were so outgoing and giving the shirt off their backs type people. They've gone through their depression, and now that they've had this sudden improvement of I'm so happy, I'm so blah blah blah, that means that they have made the decision to go ahead and kill themselves. They feel relieved that they've gone ahead and made this decision to commit suicide. So now, yeah, they're going to be happy because they've made that decision. They're going to be happy that they don't have this looming over their heads that, that they don't have to worry about it anymore. So if you see them, they haven't gone out with their friends in a while, they haven't done any of this in a while, we want to make sure that it doesn't get worse. A suicide plan, I always ask, if a patient tells me that they are suicidal, I ask them, do you have a plan? Have you attempted that plan? Anything like that. Personal interaction is important. Don't argue with, threaten, or indicate using force. Scene safety. Identify and treat any kind of life-threatening problems. Perform that secondary assessment. Detailed exam only if safe. Reassess frequently and notify your receiving facility. Alright, so let's think about it. Your patient is a 23-year-old male. His girlfriend called 911 after a domestic dispute. He is uncooperative and refusing treatment. The girlfriend reports patient is depressed and suicidal. He owns a gun and has threatened to shoot himself. So, can we treat this patient if he did not call? Yes. Okay. We're going to go ahead and treat this patient. We may be a little bit more relaxed or stepped back from this patient, even though he didn't call. We're going to go ahead and, his girlfriend is concerned. Use that. Use the fact that, his girlfriend is concerned about him and that we're all concerned about him. Should you believe the girlfriend? Whether or not you believe her is irrelevant. If he's making those statements to her, then she has to, fill out an affidavit and, verify that he's made those statements, and then it's up to the docs and the therapist at the hospital to figure all that out. Okay. So does the patient need treatment or transport? Yes, they do. Can you treat this patient against their will? Yes and no. We can, if the patient starts to make those threats, then yes, we can do that. If the girlfriend is willing to write an affidavit that says that the patient made these threats to harm himself, then yes, we can take those. There's a lot of paperwork. The police officers on scene will do some type of 96-hour hold on this patient. They'll write an affidavit, and they'll basically take this patient against their will. What should we do? Again, we want to make sure that patient is fine and has the support that he needs, has the help that he can get. So we just want to make sure that we're all in there. So aggressive or hostile patients, we want to consider some clues, dispatch information, information from the family or bystanders, and the patient's stance or position in the room. Make sure that there's an escape route. Don't threaten the patient, and stay alert for any kind of weapons of any type. Ensure safety, calm the patient, perform a thorough assessment, and restrain the patient if necessary. We want to do our scene size up, request additional help if necessary, seek advice from med control if necessary, watch for sudden changes in behavior, reassess frequently, and consider restraint. Reasonable force and restraint. So reasonable force is the force necessary to keep the patient from injuring self or others. Reasonable is determined by the patient's size and strength, their type of behavior, mental status, and available methods of restraint. Some systems do not allow for restraint without police or medical control orders. So never attempt restraint without proper legal authority and sufficient assistance. If you're going to restrain a patient, make sure that you've got enough people. You've got at least 4 people that can take an arm and a leg, and that you've got another person that can control the head and place the restraints on the patient. So it's not just physical restraint, it's, placing soft restraints on that patient. So yeah, I mean, make sure that you've got enough assistance to do that. So excited delirium. The patient is extremely agitated or psychotic behavior during a struggle, followed by cessation of struggling, respiratory arrest, and then death. The patient is often hyperthermic and shouting incoherently, and it's usually preceded by cocaine use. Often linked to improper restraint in a position where the patient cannot expand their chest to breathe adequately, and we call that positional asphyxia. And be alert for the sequence of events. Okay. So restraining a patient, have adequate help, plan your actions, stay beyond the patient's reach until prepared, and act quickly. So one EMT talks to and calms the patient, requires 4 persons at each limb, restrain all limbs, and with the approved leather restraints or soft restraints in a supine position always. So the EMT is responsible for restrained patient's airway. We want to make sure that we adequately secure the patient throughout the transport. Apply surgical masks to the patients, to the spitting patients. We at my service have spit hoods, so we can place those on those patients. Reassess frequently and document thoroughly. So transport to an appropriate facility. Not all hospitals are prepared to treat behavioral emergencies, so you want to choose the correct facility based on capabilities and local protocol. So medical legal considerations, consent. Refusals and restraints can cause significant medical and legal risk. Laws typically allow providers to treat and transport patients against their will if they are a danger to themselves or others. Local protocol may require medical control contact and or police presence. Ours does not. Here in Missouri, we can go ahead and restrain a patient if they present that danger to themselves or others and they're refusing to go with us. And we've got PD on scene, so I typically tell them, hey, you've got 2 options. You can either go in the back of a cop car with them, or you can go with me. And verbal de-escalation is huge. You've got to use some kind of verbal judo, verbal karate, whatever you want to call it, on these patients to get them to do what you want and think that it was their idea. So, sexual misconduct. Behavioral patients, especially those requiring physical contact, such as restraint, sometimes accuse EMS providers. We want to make sure that we have a same-sex provider to attend to the back of the patient. Have third-party witness present at all times, on scene and during transport, if at all possible. Okay, so we're going to watch this video of the application of restraints. Maybe.
Occasionally, patients will need to be physically restrained during ambulance transport. These patients are usually severely agitated, combative, and violent for a multitude of reasons. Keep in mind that medical emergencies such as hypoglycemia, hypoxia, head injury, and intoxication can cause a patient to become unruly too. Never assume that the patient is simply acting out or trying to be difficult. While you may need to restrain the patient, a thorough assessment and treatment for any medical cause of combative behavior should be happening simultaneously. When the determination has been made that the patient is a danger to himself or others, reasonable force and restraint can be used. Reasonable force is the minimum amount of force used to control the patient. The goal is to restrain the patient, not to hurt them. Physical restraint is always the last option and should never be used as a punishment for a rude or uncooperative patient. Never attempt to restrain a patient alone. Positional asphyxia has been reported in the literature when patients have been hog-tied or restrained in a manner that impairs breathing. Patients should be restrained in a face-up or lateral position, never face down. In many areas, law enforcement or medical control must authorize restraint and treatment of patients against their will. Quickly perform a scene assessment. Make sure that the scene is safe and that the patient is not carrying a weapon. Have law enforcement ready to assist if the patient is carrying a weapon. Try to have an exit strategy and stay at least an arm's distance from the patient until actually ready to begin the restraint process. When the application of soft restraints is determined to be necessary for the protection of the patient, crew, or bystanders, take the following steps. BSI precautions. Plan your actions ahead of time. At least 4 people are required to restrain a patient. Each person should be pre-assigned a limb to restrain. Rescuers should all act at once to overwhelm the patient. Attempt to grab clothing or large joints. Avoid placing pressure on the neck, chest, or face to avoid interfering with breathing and/or getting bit by the patient. Secure all 4 limbs with approved restraints. The patient should be secured on the ambulance gurney or backboard in a supine or lateral position, usually with one arm up and one arm down. Placing a sheet or blanket over the lower half of the body can help prevent the patient from kicking. It is a good idea to have oxygen on the patient due to the medical causes of combative behavior. The mask will also prevent the patient from spitting on rescuers. Continually monitor distal circulation in restrained extremities to ensure the restraints have not been applied too tightly. If a restraint needs to be loosened, get help and loosen only one limb at a time. Once restrained, do not leave the patient at any time. Consider having extra personnel in the ambulance's patient compartment during transport in case the patient escapes restraint. Do not remove restraints unless sufficient personnel are available to control the patient, usually at the hospital. Do not allow the patient to talk you into removing restraints by promising to behave. ABCs should always be monitored in the restrained patient. Patients that appear to calm down may actually be deteriorating, so be vigilant. Attempt vital signs every 5 minutes in patients whose conditions are changing or are critical, and every 15 minutes in stable patients. Document why and how the patient was restrained. If the patient continues to struggle violently, requiring multiple people for restraint, consider ALS resources for chemical restraint.
So, chemical restraint is something that we do as paramedics. We can give certain medications to chemically restrain a patient. And really, honestly, if you're going to physically restrain a patient, you should probably chemically restrain that patient as well. And make sure that they are safe and secure. Alright, so chapter review. As an EMT, you will respond to many behavioral emergencies. Be sure to ensure your own safety before entering a scene or caring for a violent or potentially violent patient. A considerable portion of the population has a diagnosable psychiatric condition. However, not all patients are violent. It is important to remember that patients in crisis are patients and people who need your compassion as well as your care. Always consider patients acting in an unusual or bizarre fashion to be experiencing an altered mental status. This will help you avoid avoid overlooking a medical or traumatic cause for the patient's problem. Because treatment of these patients usually requires long-term management, little medical intervention can be done in the acute situation. However, the way you interact with the patient during the emergency and assess your patient throughout the call is crucial for their continued well-being. Remember, safety is the first priority when approaching a patient with altered mental status. Psychiatric and behavioral emergencies are prevalent in our society. EMTs should treat them as they would any other potentially life-threatening disorder. Assessment of altered mental status should rule out physical causes first. Psychiatric and behavioral emergencies can present differently depending upon the disorder. There are best practices that EMTs can employ in approaching, assessing, and treating such patients. Follow local protocols and use appropriate procedures to restrain patients when necessary. All right, so questions to consider. Again, these questions are just there. I want you to think about them as you continue reading throughout the chapter and finishing out the lecture. So what methods help calm the patient suffering a behavioral or psychiatric emergency? What can you do when seeing size up reveals it is too dangerous to approach the patient? And what factors help assess the patient's risk for suicide? So you respond to an intoxicated minor who is physically aggressive, threatens suicide, and whose parents permit you to treat, but not transport the patient. How would you manage this patient? So safety, may have to call for PD. So you need to also talk to the parents. You could potentially refuse. You could do a patient PRC on this patient. However, I would strongly suggest to the parents and try and convince the parents that they need the patient to be transported. If he's threatening suicide, you can legally take the patient in against their will, their parents' will. I know it sucks, but technically you can. But getting the parents on board is helpful 100% of the time. So, and then just again transport, any kind of problems, treat any kind of problems that the patient may have. So, if you have any questions, you can give me a call, text me, email me. Let me know if you have any questions, and I'll answer those questions. And I will see you in the next lecture.